Well, it's a real pleasure for me to introduce our next speaker, Dr. Michael Georgieff, who will address iron deficiency and the infant brain in the first 1,000 days. Dr. Georgieff and I were fellows together, and we've been colleagues and friends for the last 30-odd years, so I feel a personal connection to this talk. He's a professor of pediatrics and child psychology and director of the Division of Neonatology at the University of Minnesota. In addition to attending on the NICU, Dr. Georgieff is director of the NICU Follow-Up Clinic, director of the Neonatal Nutrition Support Service, and director of the Center for Neurobehavioral Development. He's also served on the Academy's Committee on Nutrition. His research focuses on fetal and neonatal nutrition, and specifically the effect of fetal and neonatal iron nutrition on brain development and neurocognitive function. Please welcome Dr. Georgieff.
Good morning, everybody, and welcome. And thanks for showing up. This is great, and thank you to the Academy for letting me talk about a subject that I'm pretty passionate about and that I think you heard kind of in the introduction. It's actually two topics. There's the topic of iron deficiency, and then there's the topic of the first 1,000 days. And I think we're going to try and link the two of them to try and impress on you the importance of early nutrition and iron really standing as a paradigm for early nutrition and the developing brain. But it might surprise you how early is. And so let's take a look at this. I actually have a research grant from Mead Johnson to study biomarkers of brain iron deficiency, and you're going to actually find out why as we go through the talk, but that has no conflict of interest for this presentation. And what I'm hoping to do is that by the end of the talk is that you can define the common causes of iron deficiency in newborn infants and toddlers. The whole idea that newborn infants can be iron deficient is a relatively new topic. I think we classically think of toddlers as the ones who are at risk for iron deficiency. And I'm going to argue that, in fact, there's a good reason to think that newborn iron deficiency, or your endowment as you come out, actually has a lot to do with who shows up with iron deficiency in your offices when you screen for this at 9 or 12 months of age. We want to talk about the regions of the brain that are particularly vulnerable to early childhood iron deficiency, and then to foster a plan of action, both at the policy level and in a practice level for populations that are at particular risk. So some very, very smart people a long time ago really laid down the basic principles of nutrition and brain development and how the two interact. So any positive or negative effect on brain development is going to be based on two things. I know it looks like there's three. There's two there. One is the timing, and timing turns out to be incredibly important. And then the dose and the duration of the exposure. So how bad is the deficiency and how long did it go on for? And the reason for that is that we like to talk about nutrition in the brain, but the brain is really not a homogeneous organ. It's actually made up of many organs. Talking about the brain is kind of like talking about the thorax. There's lots of things in your thorax. They all kind of intercommunicate, but they are all different things, lungs, heart, and so on. Same in the brain. It's made up of multiple regions and processes, and these regions and processes all have different developmental trajectories. And so the vulnerability of any brain region to a nutrient deficiency or to overload is going to be based on two things. When that nutrient deficit is likely to occur in a population, we're going to talk about iron. Iron deficiency is not equally common throughout the pediatric lifespan. There's actually times when you're more likely to be iron deficient than other times. And what's the brain region's requirement for that? After all, if it doesn't need iron at a time when it's common to be iron deficient, then it's kind of no foul, no harm. This is one of my favorite slides, and unfortunately I really don't have a pointer to do this very well. I'll do it over on this one. This is your brain development across the lifespan. And what I'm going to try and impress on you is why we're so focused on that idea of 1,000 days. What you can see here is that brain development starts well before birth. Many processes, including rapid hippocampal development, myelination, even the prefrontal cortex. Who knew that babies could prioritize and have attention and inhibition? And certainly your brain hooking itself up all start in this period prior to 2 years, and much of it, in fact, is prior to birth. And so that's why we refer now to the first 1,000 days as your golden opportunity to influence, whether you're talking about nutritional influence, environmental influence, social influence, reducing toxic stress, whatever it is in terms of brain development, this is why we're so focused on it. You'll notice that many things that we consider later forming, like higher cognitive function, still has its onset pretty early in life. This is 12 months of age right here. And you'll also notice that things kind of come to a grinding halt later in your pediatric career. And for most of us, we're also very happy to see that you continue to learn throughout your lifespan. This is a list of nutrients that particularly affect early brain development and later adult function. And you can see it's a fairly large list. These are all ones that either show a critical or a sensitive period for neurodevelopment early in life, or where early deficiencies have been shown to cause long-term dysfunction, or where there is even evidence for epigenetic mechanisms for underlying those long-term changes. So let's talk about iron. Why worry about iron deficiency? Well, there are, 7 billion of us out there now, and fully 2 billion of us are iron deficient. That's a World Health Organization estimate. And it has a particular tropism for pregnant women and for young children. And in fact, those numbers go up to 30 to 50% of the population and approaching 80% in low and middle income countries. Every cell out there needs iron for proper development and subsequent function. It's that fundamental. It's in your cytochromes, it makes ATP, it is basically what causes that very rapid development of the brain to happen. And as you all sit out there, 20% of your oxygen consumption is your brain. In a newborn baby, 60%. That's that brain becoming more complex, hooking itself up. And substrates like iron, oxygen, glucose, and so on are the main drivers of that. You all know that iron deficiency anemia is associated with clinical symptoms, but the important thing to remember is that although anemia makes you feel bad, you can take care of the anemia. You transfuse somebody, for example, and the symptoms will remain. And that's because it's the tissue-level iron deficiency that's the problem. Now, if you talk to adult hematologists, and I do fairly frequently, they'll say, what's a little iron deficiency? You get a little anemic, you give them some iron, the anemia goes away, problem solved. Unfortunately, during development, that's not the case. So the main reason to worry about iron is its effect on the developing brain. And true, some effects of iron deficiency on the developing brain are temporary, that is, while they're iron deficient. But what's concerning are the long-term effects. And there are now studies from Betsy Lozoff's group that go out 25, 30 years to show the consequences of having been iron deficient in that newborn period. And that's your real cost to society. You know, I think all the talks you've been hearing about are cost to society. This is your real cost to society in terms of nutrition, whether it's iron or whether it's any other critical nutrient. The long-term costs for iron include depression, anxiety, schizophrenia, risk of autism, and this translates then into loss of job and educational potential. So basically the same idea as in developmental origins. The brain is being scaffolded early on, and early nutrients, early nutritional integrity makes a difference in terms of what you will get later on. Why? Because iron is important for all sorts of processes in the brain. I'm not going to go through all of these in any detail, but they're important for myelination. They're important for that energy status in order to build the brain. They're important for monoamine neurotransmitters such as dopamine, so it affects mood and affect. And probably the most interesting findings most recently are effects on the genome, both during iron deficiency and long after the iron deficiency has been treated and resolved. There's evidence that iron works through epigenetic modification, particularly of synaptic plasticity genes, and it does this through histone demethylation. So if we return now to our map of brain development, we're going to concentrate on a couple of time periods where iron deficiency is fairly common. Iron deficiency is common in the fetus and the neonate. It's common in infants and toddlers. And again, there's a peak out here during the teenagers. We're not going to talk about those. The one here in the fetal and newborn period is one that is going to affect our scaffolding the most, whereas the one out here in infants and toddlers is more likely to affect higher functions, particularly frontal lobe functions. I'm going to show you how the data actually lie right in there. So there's your timing effect. So you can expect that iron deficiency in these two fairly close. It's not too far apart time-wise, but you'll get very different behavioral phenotypes from them. So the fetus. You accrete your iron in the last trimester. Fetuses have about 75 milligrams of elemental iron per kilo during that third trimester. So if you're born at term, you've got about 250 milligrams of iron to work with. But if you're born at 24 weeks, you don't have an awful lot to work with. So it is incumbent on neonatologists like Mark and me, for example, to provide them with the iron that they would have gotten in that third trimester. The majority of iron is found in the red blood cells. We mammals, not that mammal, we mammals, are born with a lot of iron stores. That's true actually across any number of species. And those iron stores will last kids for a while after they're born. You can account for most of the iron in a baby between those two pools, the red cells and the storage pools. But it's actually the non-storage tissue iron that's in the brain, the skeletal muscle, and so on that account for the rest. And for that, we really don't have any good biomarkers. So when we're estimating iron stores or total body iron status, we're going mostly from the red cells and from the storage pool. So what could negatively affect neonatal iron status, or let's call that fetal and neonatal iron status? Well, the most obvious one is decreased maternal iron supply. So it turns out that the fetus is a very good parasite. It will suck the iron right out of the mom. That's probably a good thing, the mom giving to her child. That will go on, by the way, for years afterwards. We're still dealing this with a 32-year-old. But in fact, the fetus can call for more iron as it grows rapidly. And in fact, as a mom becomes more iron deficient, she transfers a higher percentage of her dietary iron to the fetus. But eventually, that paradigm collapses and the whole maternal fetal dyad becomes deficient. And that happens around a hemoglobin of 85 or 8.5. Pretty common in developing countries. We don't really have any sense of how deficient that brain is. But you could have a perfectly iron sufficient mom and have disruption of delivery to the baby or to the fetus, and that occurs when a baby is born prematurely. It occurs with intrauterine growth restriction because maternal hypertension decreases placental function, and you can see that about 50% of IUGR babies are born with evidence of iron deficiency, low ferritins. Autopsy studies of those kids that we've done back in the 90s showed about a 30%, a little over 30% reduction in brain iron. And that's important because I'm going to show you a picture of a rodent model of what a 30% reduction of brain iron does to neuronal structure. And then if you have early cord clamping, so we don't call it delayed cord clamping now, we call it appropriate cord clamping. And if you just come out and you get your cord clipped, that's considered early cord clamping. But as Father Guido Sarducci said, for those of you who are older enough to remember him from Saturday Night Live, what do you remember from your economics course? Right? 5 minutes, this is the 5-minute university. You remember about 5 minutes of your university experience, any course. Well, what do you remember out of economics? Supply and demand, right? So it's not all about supply side and nutrients, it's also about demand. And we have children, fetuses, newborns, infants, toddlers, who have increased iron demand. And the classic example in utero is a baby or a fetus who is chronically hypoxic, and that's the infant of the diabetic mother. And you know, those kids are usually polycythemic when they're born, yet they have very low iron stores, and they've clearly shifted their iron from their liver stores, and it turns out their brain as well, into that big red cell mass. And discovering this was important because it showed us a very sad principle for us who are in neuroscience, and a very happy principle, I guess, for those who are hematologists. And that is that iron is prioritized to red cells over the brain and other organs. whenever iron demand exceeds iron supply. So think about that. What do we screen for iron deficiency in our general practice? We look for a hemoglobin, right? We look at a hemoglobin or hematocrit out at 9 or 12 months of age, by which time our models show us that the brain has already been affected. There are plenty of studies on neurobehavioral sequelae of fetal and neonatal iron deficiency, starting with maternal intake. Low maternal iron intake early during gestation increases the risk of schizophrenia and autism in the offspring. If you look at term kids who are born with low iron stores, they have impaired recognition memory, so the hippocampus is affected. They have poor school performance when they get to school age, and they have worse recall memory. And then preemies who have low iron stores at 36 weeks post-conceptional age, depending on when they were born, have more abnormal reflexes and slower conduction velocities. So all of this suggests both hippocampal and myelin types of impairments. And again, that lays very nicely on what I told you what the physiology is, that iron's important for myelination and iron's important for dendritic maturation. And so I just want to show you, because I think a picture's worth 1,000 words. This is your iron-sufficient brain. These are hippocampal neurons, and you see these beautiful long dendrites that hang down and make a very nice target for neurons that are entering with information from another area of the hippocampus. This is your brain on iron deficiency, and this is non-anemic iron deficiency. This is a genetic knockout of the ability of those neurons to take up iron, and you can see how disorganized and broken those dendrites look. So now let's shift to the more classic infant and toddler iron deficiency, and I think that this is worth a little story. When I first met Dr. Lozoff probably 20 years ago, she looked at me, and if any of you know her, she's just a very motherly type, and talks down a little bit. She said, "I study toddler iron deficiency, you study newborn iron deficiency, someday our worlds will meet." And I thought, okay, that sounds interesting. And what Betsy and I actually have been doing recently is finding that, in fact, many of the studies that she published in terms of iron deficiency appearing at 9 months or 12 months, that those may have been set up by prenatal or neonatal iron deficiency. So there really is a connection between the two. So let's explore why. So here's a diagram of factors that determine infant iron status, okay, at say 9 to 12 months. And I've, of course, highlighted this by putting a red box around the maternal and newborn iron status. You can see the other things that play into it. Don't forget that rapid growth, and of course we see very rapid growth in our kids these days, rapid growth makes you expand that red cell mass even more and requires more iron. Right? So she looked at this in a more formal way in a study she's doing in China right now. Every box that is in yellow is a prenatal or neonatal factor that is putting in input into what is at the bottom, which is in orange, which is the infant iron status at 9 months, right? So it's not just about the dietary intake that the kids have after they're born, it's the endowment that they bring to the table and then the rate of growth, the demand side after birth. Now, if we look at our diagram again now and take a look just at the infancy and toddler piece, you'll see that more frontal lobe types of problems are going to appear with infant or toddler iron deficiency, as opposed to more memory types of things in the newborn iron deficiency. And in fact, there are over 50 studies that show that dietary iron deficiency between 6 and 24 months leads to behavioral abnormalities, both motor and cognitive ones, and that those can be present long after iron repletion. She's got studies now, like I said, out 25, 30 years. These behaviors are characteristic of dopaminergic and hippocampal dysfunction. She's also shown electrophysiologic abnormalities, again suggesting a delay in myelination, both while the kid is iron deficient and then also three plus years later. Her data are pretty clear. You can see children with the solid lines are those who had good iron status at birth, and the spread from the 5th to the 95th percentile, and cognitive composite scores on that y-axis. And then you see kids who had iron deficiency, this is measured at 1 year of age, have slightly lower scores, But the sad thing is that chronic iron deficiency, and there are, of course, populations where iron deficiency is endemic throughout childhood, basically regresses all of that to a much lower mean out at 17 years of age. When you break it down into the domains that we would expect based on what iron does, you see exactly what you would expect. That is, for example, on the right-hand side, the orientation and engagement, which are thought to be dopaminergically driven. You can see the better performance in the iron-sufficient kids in the red bars, the poor performance of the iron-deficient anemic kids, and then that middle ground of what I call NAID, which is non-anemic iron deficiency. Again, suggesting that the brain is at risk before the baby or the child is even anemic. And you can kind of see that engagement in those two pictures. You can see the kid on top, raring and ready to go to do his Bailey, and the kid on the bottom who is not unengaged. He is looking at the tester, but who clearly is showing hesitancy and wariness. And then from the myelination standpoint, these are nerve conduction velocities, evoked potentials. These are visual and ABR. So ABR on the left and visual evoked potentials on the right. 3 years after the iron deficiency was diagnosed and treated. And you see the longer latencies in those blue bars. Those are the formerly iron deficient anemic kids. So slower rate of processing. So what does this tell us? Well, for the first half of the talk, which was about the first 1,000 days, we see that certain nutrients have a high impact on early brain development. I gave you that table, and I've highlighted iron. I've spent my career studying iron, but iron actually serves as a very nice paradigm for any of those other nutrients as we think about nutrient and brain interactions. You really do have a golden opportunity in those first 1,000 days or from 0 to 3. That greater impact in fetal, neonatal, and early infancy time is due to the velocity of brain growth. Your rapidly growing brain requires higher nutrients. So the policy and the practice implications are to actually ensure the newborns that we see that they are bringing a full complement of nutrients to the table. And that means shifting the conversation from diagnosis and treatment afterwards, after birth, although that is important, to ensuring maternal sufficiency during pregnancy. I'm sure you're aware that there are policy statements out there being revised as to how much we should be supplementing moms during pregnancy. That sufficiency, however, really starts preconceptually. And then that begs the bigger question of when do we break the cycle? Do we break this in non-pregnant women and men? And who knows how they're planning on becoming pregnant or not. But that appears to be the place that we want women to be, is nutritionally sufficient going into their pregnancy, maintaining that sufficiency throughout pregnancy, and then so that the child brings a good endowment to the table. And I think the second place that we could have some policy changes would be an earlier screening of nutritional status in the infant. So should we, for example, we screen for genetic diseases, should we have newborn screening for nutritional status? You know, we already do that with growth curves, but that's macronutrient status. You know, could we be using blood spots, for example, to assess what iron stores a baby is bringing to the table? From an iron standpoint, obviously iron plays a pretty critical role in early neurodevelopment. The key point here is that the brain becomes deficient before anemia is present. This is true in mice, rats, sheep, pigs, monkeys, and humans. So I think it's just a basic biological principle. And therefore, iron deficiency without anemia affects brain structure and function. The second shoe to drop there is that once the brain is deficient, there's a risk that alterations will persist into adulthood in spite of resolution of the iron deficiency. So what does that mean practice-wise? It means early screening of at-risk infants, knowing who those at-risk infants are. The first group we think about are those with low endowment, preemies, late preterms, okay? They've missed quite a bit of it. Intrauterine growth-restricted babies, infants of diabetic mothers. And at least the data are there for the preterms and the IUGRs that we should be probably giving them about double what the normal iron dose is, so about 2 milligrams per kilo per day. The policy implication, though, is that screening for iron deficiency by assessing hemoglobin at 9 to 12 months is not a very effective policy in preventing those long-term things. Essentially, the horse is out of the barn. So we need new tools to detect pre-anemic iron deficiency to protect that developing brain. And the WHO, in fact, is considering using serum ferritin as a screening tool. So I'm going to leave you with those thoughts that we are pediatricians, we take care of the kids after birth. The brain doesn't really care when it's born. Big event for the mom, not such a big event for the brain of the kid, and that's a continuum of nutrient input into that developing brain. Scaffolding it from the beginning is the right way to do it. Thanks so much.